Good afternoon, ladies and gentlemen. My name is Dr. Asavri Savan, and it's my pleasure to welcome you to the episode 4 of Live Panel Discussion on Detect to Protect, Bridging Gap Between Diagnosis to Treatment in Breast Cancer, on behalf of Voice of Healthcare, powered by Zydus. As we are all aware, 4th of February is marked as World Cancer Awareness Day. All the health workers join hands together to create awareness about this disease. This year's theme for World Cancer Awareness Day is Close the Gap. Sorry. So, for this episode, Voice of Healthcare brings leading minds and experts from all fields of oncology together on this exclusive session to do our bit for achieving the same. So, let me begin the session by inviting our eminent speakers. I welcome Dr. Sandeep Nayak, Director, Department of Surgical Oncology at Fortis Hospital and Chief Surgical Oncology at MACS Clinic, Bangalore. Welcome, sir. Next, I'd like to invite Dr. Joy Ghosh, a Senior Oncosurgeon at Sahadyri Hospital, Pune. Dr. Joy Ghosh will be with us soon. Next, I invite Dr. Poonam Patil, Consultant of Medical Oncology at Manipal Hospital of Old Airport Road branch. Welcome, ma'am. Next, I'd like to invite Dr. Tejal Gorasia, Surgical Oncologist at Onco Cancer Center, Maharashtra. Welcome, ma'am. I welcome everybody to this panel discussion. We are thankful for Dr. Tejal for leading this session for us today. Now, over to you, ma'am.
Good afternoon, everyone. It is great to meet you people. I am very new in this field. Basically, today, since it is bridging the gap between diagnosis and treatment in breast cancer, there will be a few questions which I may just to and fro between you. So, first of all, we'll understand what is the status of breast cancer in India. So, question to Ma'am Poonam Patil, Madam. So, what are the different types of breast cancer that are common in the Indian population and how different they are as compared to the Western population?
Okay, so breast cancer is the most common cancer in Indian women, and it is becoming more common over a period of time because lifespan has increased and also the population is more affluent now, more aware now, and incidence has increased over a period of time. So, as of recent statistics, approximately 26 women out of 1,000 are affected with breast cancer in India. And of the affected women, 12 may die due to breast cancer, which is very high number compared to the West. And about 1 in 10 women are diagnosed with breast cancer in their lifetime. And there's a good chance of recovery if it is detected at an early stage. And you asked also a question, what are the different types of breast cancer which can develop in different parts of the breast? Now, it's a very ambiguous question. So one can classify the types of breast cancer in many ways. One is depending on whether it is precancerous or cancerous. The precancerous stage is also known as ductal carcinoma in situ, and the other one is invasive breast cancer, when the cancer cells have spread through the lining of the ducts into the surrounding breast tissue. So, this is the most common type of breast cancer. This can again be ductal, that means it starts in the milk ducts, or lobular if it starts in the milk gland or lobule, as we may call it. There's another type of cancer which is known as inflammatory breast cancer, when the entire breast is swollen, red, and painful due to cancer. So, this is based on the location of the cancer where it started. And also, if it is localized to the breast, then we call it as localized. If it is also spread to the regional lymph nodes, then we say loco-regional or locally advanced. And if it has spread elsewhere to other body organs, we call it as metastatic disease. There's another way of subtyping the breast cancers depending on their receptor status. Receptors are, we identify some molecules on the cancer cell by special methods known as immunohistochemistry. So, most commonly tested are the hormone receptors and HER2 receptors. So, if they are hormone receptor positive, it is known as hormone receptor positive breast cancer. If HER2 is positive, we call it as HER2 enriched breast cancer. And breast cancer that does not have hormone receptors also, HER2 receptors also, they are known as triple negative breast cancers, which are a little aggressive type of breast cancers.
And ma'am, what is the difference we are seeing between the Western population and Indian population? What differences do you think
Yeah.
we are finding?
So, in the Western world, the breast cancer is generally a disease of postmenopausal women which are over the age of 50. Of course, younger women can also get breast cancer, and that is the disturbing trend that is seen in India. Though the incidence of breast cancer in India per se is lower than in the Western countries, the mortality rates are disproportionately higher. Also, the type of breast cancer that I told you, hormone receptor positive breast cancer, which is supposed to be of better biology, is lesser, and triple negative, which is supposed to be of aggressive biology, is more in India. Added to that is the younger age of population or younger age of patients, late presentation either due to ignorance or fear, that makes the outcome poor compared to the Western counterparts. Almost 30% of women in India present with locally advanced disease, and 20% have metastatic disease at diagnosis. This is very dismal compared to what we see in the Western countries, where most of the times the disease is diagnosed through screening tests like mammogram, and the patients usually do not present in the advanced stage that we see in India.
My next question is to Dr. Nayak, sir. So the current treatment options for breast cancer, usually they follow the safer treatment, more effective treatment and all those kind of when we talk to the patient. So earlier approach was we used to do complete removal of the breast or what we say as mastectomy followed by chemotherapy or radiation therapy as required. So what do you think? Is there a change which we are seeing today in the management?
See, a lot has changed in the overall management of breast cancer because it's, as we see it today, breast cancer is one of the most researched cancers that exist today. So, because of that, a lot has changed because initially, where, all the importance was given to a radical mastectomy, and then there was a changeover to, extended radical means, you were removing full breast, but then, you went on to remove more than full breast means, chest wall muscles and all those things were removed. And then the things started changing from that era to an era where, we started thinking of saving the breast and doing a better reconstruction, and a lot of other things started coming into the picture because there was a paradigm shift means, there was a shift in the thinking process of the medical fraternity, that, the results of what radical surgeries were giving, or, very very extensive surgeries were giving, were same as when we save the breast. So when we saw that, that was about maybe 30 years or 40 years back, when we started realizing that more modern things started coming into the play. And, today when we see, we are, if a patient, a breast cancer patient desires to save the breast, we are, in most of the cases, we are able to save by doing breast conservation surgery or oncoplastic reconstructions. Also, there are times when a patient, for some technical reason, needs to lose the entire breast tissue. It is possible to do a complete removal of the breast tissue from under the skin, what is called as nipple areola sparing mastectomy, and at the same time we can do a reconstruction. So we can remove tissues from some other part of the body and reconstruct the breast and give almost normal appearance to the lady. So it's a question of desiring to save the breast, and if the person or the patient desires to save the breast, today in many cases it is possible. So there are many things which have changed. In fact, today, if you see, even for example, when we believe in breast cancer, we generally say most of the patients will end up in all the forms of therapy, like be it surgery, radiation, chemotherapy, and hormone therapy in many selected cases, the target therapy. But at least the first three, that is surgery, chemo, and radiation, most of the patients will end up. Now there is, there was a set sequence, like you told me we'd start with surgery, then go for chemotherapy, then go for radiation. Today we also know that some cases it is beneficial to do chemotherapy first and then take the patient for surgery. We don't have to do surgery first. So we know today that the outcomes may be slightly different when we do chemotherapy first in certain cases. So there are many things that we have learned over time which has changed, changed the way we manage the cases. So it's an interplay between these things, which is which is tweaked in slightly, we can get a slightly better result than what it was a straightforward answer. So today, before we start a treatment, we want to understand the disease. So that's why we do every test possible before we start the treatment.
Very nicely put, sir. So basically, right now we can offer the patient what she wants. So her considerations are taken in this. I would like to welcome Dr. Joy. He has joined us. So, question to you, sir. How important is timely screening, establishment of standard treatment protocols, and what do you think whether the current status is applicable to our day-to-day patients?
Yeah, so question in three parts, so I'll answer it in three parts. First thing is timely screening. Unfortunately, screening as a concept is not very popular in India yet. We don't have any stringent guidelines for screening for breast cancer. Whatever we are doing is sort of replicating the Western guidelines. So every time we also read in our books or we recommend to patients, the guidelines come from the National Cancer Network, which is the NCCN, or it comes from the US Preventive Task Force. So these are the two commonly followed guidelines, and we also in India follow those guidelines as well. They recommend that beyond the age of 50, you should start screening with a mammography. Other than that, self breast screening and clinical breast screening is also there, which is very simple to do, and every woman can definitely do that by themselves, doesn't involve any investigations. But screening mammography to recommend, we Indians don't have any strong data from our country. We have to rely on the West for their data and extrapolate to our population. Now, coming to how it applies to our population, like I said, the awareness has to increase so that our screenings are mostly patient based. They voluntarily come in and get themselves checked. And this can only increase by awareness. So, things like health camps and many corporates also have the yearly health checkups. So, mammography can be included for women in these age groups, and that would help screen these patients even though they don't have any other illness.
And sir, do you think, as you said, in the normal guideline, what NCCN guidelines are suggesting, are we able to follow in our day-to-day practice? So, and
Yeah.
if not, then what are the changes we can bring in so that our patients may follow the guidelines or at least come for screening? So, how do we propose the changes? Just like Tata said, ki USG breast is good enough, don't do a mammography, or biannual is enough, don't do annual. So, whether we can bring in certain changes in the recommendations which we are following on Western lines.
So I would say that mammography and sonography always go hand in hand. Uh, Currently, if I had to screen a patient and give the proper advice, I would say you have to undergo a mammography plus sonography, and that is actually what will give you the correct results. However, if I have only one investigation to choose, then USG is the more commonly available one, and patients have better access to it, and good sonologists can definitely pick up a breast lesion very easily. Mammography screening is the one which is standard of care in the US. So it's not sonography. What is recommended is screening mammography starting at 50 and yearly after that. Like our population has breast cancer. I mean, we see that the breast cancer patients are younger compared to the Western population. They are one decade early. So if
Hmm.
screening start at 50 there, probably it will start at 40 here. And yes, biannual is another method that you can say that yes, biannual is a alternate to doing an annual mammography. So that's a doable thing. That's not a problem. But then again, the concerns start that you may miss a small cancer in that 2 year period. So it's like either you should do it properly, or then if you are trying to do makeshift arrangements, it might not work as it should.
Okay. Next question is to Dr. Nayak, sir. So, what are the options usually we suggest for breast reconstruction? And do you take hormone receptor status into consideration when you're considering conservation surgery or a reconstructive surgery?
Okay, so see, okay, second question first. To us in
Okay.
our practice, I don't think it really matters what hormone status is, how aggressive the tumor is when we consider for breast conservation, because it is totally guided by the desire of the patient to have a breast conservation, and the point number two, by the T size or the size of the tumor, it should be feasible to do it. So these are the two criteria which we follow when it comes to breast conservation. So if the two criteria are met in most of the patients, it is okay to go ahead with breast conservation. Again, here again I want to point out to you, see, the patients who have genetic reasons to get cancer, like the what we popularly know about BRCA1 BRCA2 patients also, if you see all the international guidelines, what they talk about is, you can go for breast conservation provided the patient follows a good follow-up pattern. It's not a contraindication for going for breast conservation even when BRCA1 BRCA2 are positive. So, having said that, you coming to the first question, that is, what are the reconstruction modalities available to us? Now, reconstruction depends on the volume loss. So that is, how much of the breast tissue we are losing when we are performing the surgery. That is what will tell us how much we have to, uh, or how much effort is required to reconstruct that area. So generally we would say, if it's a smaller tissue, we just need to reconstruct smaller. So there are times when we can simply rotate the rest of the breast tissue and close that area. It gives a very good cosmesis without much of a much of hassle of reconstruction, because remember, whenever we do a reconstruction, patient has to go through the pain of reconstruction also. So to avoid it, it is sometimes better to go for local tissue reconstructions. So when we require, we have multiple options. That is, we have an option of using some tissue which comes from some other part of the body, which is called a free tissue transfer or microvascular flap reconstruction, very popularly known as a DIEP flap, which we do regularly for deserving patients. Again, other side of it, what we call as latissimus dorsi flap, which comes from the back. So that's also a good flap for us to reconstruct, simple reconstruction. We can sometimes place you know the silicon processes for reconstruction, not alone, but along with some other flap, it's possible to do. So there are many ways in which we can reconstruct a breast based on how much we are removing, depending on a small portion versus reaching to the entire breast. So it's a gamut. It's an entire gamut of various modalities or the ways in which we can do that. But here, very important thing I want to tell. See, whenever we reconstruct the breast, it is only a cosmetic reconstruction. People get confused. They think, the very common question which I come across is, will a reconstructed breast have a higher chance of recurrence of breast cancer? They ask every time. Every patient asks this. The thing is, it is not breast tissue which we are reconstructing. We are getting some other fat and muscle tissue to give a cosmetic appearance. So the risk of or the reconstructed tissue per se does not have a risk of breast cancer coming in that tissue. Other factors may apply. That is, breast tissue which is there in the skin flap itself, or the skin over the breast tissue itself. Those are completely unrelated things. But the tissue which you are transferring does not have a higher risk of breast cancer. It is a different tissue. It is not breast tissue. So for this reason, that aspect of it you don't have to think about.
I would just ask one this in our experience. Basically, I don't know, to Joy sir as well as Sandeep sir. After getting an oncoplasty in our practice, Whether reconstruction, I mean DIP flap and LD flap, have we reduced on it or we have the same numbers after
I would say,
incorporating oncoplasty in our practice?
see,
So whether
most of the
have we reduced?
patients, most of
Otherwise,
the
earlier we used to just
patients,
primary close it.
see, we follow the reconstruction ladder basically. It is based on how much volume is lost. So there are below 25% you can most of the times, or 20% you can most of the times primarily close it. Just a rotation over there itself is enough. The oncoplastic rotation, like the local breast flaps, are required or useful up to 40% of the breast tissue loss. So these are, I didn't want to go into these theoretical aspects, but definitely, we use the breast flaps quite commonly.
Yeah.
What I think you asked Dr. Joy also for his comment.
Yes, Dr. Joy.
It's not two exclusive things. They're not mutually exclusive. That if you use a flap, then oncoplasty is not done. So these are higher level oncoplasties. When you use a LD flap or you use a DIP is a whole breast reconstruction, and LD is a partial breast reconstruction. So LD is considered only a type 2 or a level 2 oncoplasty, where you are bringing in foreign tissue and implanting into the breast. So that is also an oncoplasty. I think what you meant to say was local rotation of tissues, as sir was
For
describing.
local rotation, whether
Yeah.
we have reduced the LD flap use.
No, so
Mainly
again, like
LD flap
it
is
depends
usually
if the
complete
patient needs it.
reconstruction.
No, if the patient needs it, you cannot get away with something lesser. You have to do what is required for that patient. If
That's what
without
I
that, there
wanted to.
is
Uh,
yeah, yeah.
that's what I
Without
wanted
that,
to subject.
oncoplasties and reduction mammoplasties definitely yes, they are increasing in use, but that doesn't mean that what is maybe a local flap or a rotation flap has to be done. It has to be done. You cannot change that.
Yeah. Thank you. My next question is to Dr. Poonam Patil, ma'am. Ma'am, what do you think are the barriers you have seen in your practice to screening? Just like Joy sir has said, ki the patient are very much reluctant for screening. So, what are the main barriers that you have faced in your practice to screening?
So yes, agreed. What he said that the adoption for cancer screening has been consistently poor in India, despite all efforts of doctors and nationwide screening programs run by the government. Even self breast examination, women cite excuses. So they often say, what I have seen in my practice, that for self breast examination, why they did not do, they said, I forgot, or there was lack of time. For going to a doctor for a clinical evaluation or for mammogram, I think psychosocial barriers are the most important here for taking screening procedures. So they fear the social stigma, especially when it threatens, say, their daughter's marriage, or there are some financial difficulties and healthcare system related factors. They don't want to come to the hospital, so that if somebody knows that, oh, this lady has gone for a breast evaluation, probably she has a cancer. So they are all ostracized, and it is still a mindset that needs a change from the patient also and from our society also. Fear of the impending financial pressure that the treatment may put on the family is again something very important in Indian context. Sad thing is that very educated women also have ignored the breast lump, which they felt a few months back because it was not paining. Now, most of the times, the breast lumps that occur in cancer are not painful, at least to begin with. But even educated women, they feel that the lump is not painful, and COVID has done this thing even more bad. They feel that if I have to go to get this breast lump checked, I will get COVID as a byproduct of going to the hospital, and that may be fatal. They don't realize that cancers themselves could be fatal if they are ignored for long. And that because of children's exams, because of relatives' wedding, we have had many weird answers sometimes when we ask that why did you not come for check. They say that we are going scared of going to the hospital. Nobody in my family had a cancer, so I also may not have cancer. This lump may not be cancerous. And never been to a doctor. I checked my symptoms on Google and it did not suggest that it could be cancerous. I took some alternative medication. Somebody gave me some paste to apply and said that this will heal away. And I do regular exercises. I follow all healthy habits. So it's very unlikely that I will have cancer. So these are all kind of weird answers that we get when we ask that why did you not go for screening procedures? Now, justified or unjustified, I think it is and awareness that needs to be increased for improving screening.
So basically, we have got two common enemies. One is basically uneducation and Google. My next question is to Dr. Joy. Sir, what are the initiatives you suggest we can build up for creating awareness and also basically awareness about the treatment, awareness about the quality of life after treatment, and also to counsel the relatives for getting checked up because a breast cancer, as we know, if a person has got in a family, we would always have preferred to have a family get them evaluated for maybe genetic predispositions and all. So first part of the question, how can we build up awareness in the patient regarding the treatment?
So now in India, the situation is slightly different from the West in that there are no government health schemes which recommend screening. So the reach that you will create awareness is mainly based through private hospitals. I think most of us are working in private setups, and whatever programs are held or there are awareness camps held, like for example, Cancer Day. So 4th of Feb is held as Awareness Day for cancer. In the same month, many such hospitals or corporates will hold such camps. So this is one way which is being followed since many years now, that general patient awareness or going to little more educated people who can understand the meaning of it and then counseling them or explaining the benefits of what it means. Other than this, actually, if you look at the truth, then the uptake of or understanding of screening is lacking in a lot of basic level physicians, general practitioners. So, a general practitioner has a big role to play in counseling any kind of patient who comes to him for any other illness. So, for example, today I have a cough or a cold, and I go to a general practitioner, and that person I actually counsel a person or a person, woman of a age group which is due for screening, or at least explain about self breast examination. It will go a long way in bringing this to the patient's understanding and knowledge. So I think even educating of doctors is necessary. The physicians, the surgeons who are not that oriented to breast cancer treatment, this will also help improve the patient education as well as understanding. So I think other than this remains the government health schemes or government awareness programs, which is not very much in cancer. I mean, it's not there for screening of cancer. Yes, cancer ke bare mein there is a lot of information given out, but screening specifically is not touched upon in most of the places. Again, it is limited to the cancer institutes like Tata Memorial. It's there in ADR, maybe it will be there in AIMS. But again, those are big government institutes in the big metros. So these do their own part, but it is not community based.
And regarding treatment, sir, whether how the treatment is going to affect the quality of life. So how do we make aware that after the patient has to undergo chemotherapy, radiation, whichever is prescribed to him, in order to complete the treatment, in order to get a good quality of life after the completion. So basically, it is
I
very
think
difficult to counsel the patient and the
Yeah, so
relatives.
I'll give you a genuine example that Nayak Foundation, which is run by Dr. Shona Nag. So she has this support group or a big support group foundation which is there. I mean, through the foundation which is there, and this includes patients who are treated 20 years back, also coming up all the way to the patients who were treated last month. Now, what happens here is that they get together, they do hold programs or counseling sessions. Rebecca is a very active member of this foundation, and also in the terms of counseling of patients and giving them hope that yes, this disease is something that you can get over. This is an extremely important part that is played by her and her colleagues, and this is done in a big way in maybe once in a year or once in 6 months, where support group conferences are also held. This in a big I have what I have seen personally is that a person who is undergoing treatment or is about to undergo treatment, if they are able to discuss their fears with somebody who has completed their treatment and is now healthy and doing well, it gives a big impact to the new patient who is now ready to start. A lot of fears are put away, a lot of treatment side effects and how they impact the later life can be explained, so the person knows what to expect. They are seeing a real life case in front of them, that this treatment what we are giving on paper, that person has actually lived through it, and this person is now out of that disease, doing well, working with a job maybe, and holding managing the family, all that is being done, and they understand that yes, this is our future ahead. So support groups, getting patient-oriented conferences, which means that past patients who can actually come in and give us information regarding their experience, definitely helps a lot in counseling a new patient.
Yeah, very well said, sir. Um, Now we will go on to the next part in which I'll be asking a common question. It will, so what measures are needed to improve the quality of life post breast cancer surgery? Question to Dr. Joy, can you please answer first? So what
What
measures can
measures?
we take to improve the
Yeah.
quality of life after a breast cancer surgery?
Okay. So breast cancer surgery has a few common complications, or you can say sequelae of the surgery. One of them is chronic pain. This is something which is ignored very often, and it can occur after a mastectomy. It can occur after a breast conservative surgery also. The biggest reason for this is handling nerves in the axilla. They get divided. There is a lot of muscle stiffness which develops after the surgery. There is a drain kept in that place for maybe 15 to 20 days. All these things end up in causing a lot of chronic hypersensitivity of the nerves and a lot of muscle stiffness at the shoulder, the chest. And this, if it is not treated in time, or if you don't intervene at the time that the person is immediately in the post-op period, they develop a chronic pain syndrome, and that is very, very difficult to manage. If they go on to develop pain for the next 6, 7, 8 months, 9 months, at that point in time, it's very difficult to control this. So, early diagnosis of such complications or such issues, and then intervening at a good time, and the physiotherapist can definitely do wonders if such a thing is encountered by them. Other than this, the body image situation, which also arises sometimes, they feel that their body has been mutilated. Those who have undergone mastectomy will have complete discrepancy of either side. So, how to go out in public, how to face somebody, they don't want to go to marriages, they don't want to go to their family functions. Unfortunately, because of the stigma related to cancer and its treatment, this is the kind of feedback that we get. So there are now options. For example, if breast conservation is possible, then yes, do go for that option. Do counsel the patient in proper way so that they understand what it means and they understand that there is no increased risk of recurrence, as sir has mentioned earlier. That with the breast conservation, with an oncoplasty, it doesn't increase the risk of recurrence, and the patient goes home with a proper treatment. That itself will help reduce this body image discrepancy that patients do face. And going out in public or meeting somebody in a public eye is definitely better for those who have a reconstructed breast as compared to those who have undergone a mastectomy or have a poor reconstruction with a poor cosmetic outcome. So this is again a surgeon's job, that we have to counsel the patient from the beginning itself regarding what options are available, and breast conservation, if feasible, definitely should be offered to avoid this problem coming up in the future. I think beyond this, whatever the sequelae of major surgery are, they usually resolve within a month or so. So I think if you have taken good care in the patient in the post-op period, the problem should not be chronic.
Another point I would like to stress is lymphedema post breast cancer surgery. Can Dr. Sandeep Naik elaborate on that point? How to reduce the chances of lymphedema in these patients?
Okay, so what is lymphedema? Lymphedema is basically the swelling of the arm because the fluid drainage system, which is the lymph nodes which are in the armpit, which are common for both breast and the arm, are removed during surgery. So that is a problem for which the patients who undergo axillary lymph node dissection or armpit lymph node dissection have a tendency to develop a swelling in the arm, in that particular arm. So it has about 40% risk if you remove complete lymph nodes. But what has happened is, we have developed, we means, the entire medical fraternity, there have been much research gone on this to reduce this long-term side effect of, lymph node removal. And that technique is called sentinel node biopsy. So basically what is done in that is there are various methods. I generally use what is called as indocyanine green lymphangiography, but there are other techniques which are available. So we identify the lymph nodes which are representative of the breast and remove those lymph nodes and send for testing. So effectively, what we are trying to do is we are trying to avoid the lymph nodes or lymphatics coming from the arm, so that tomorrow we don't end up with the swollen arm. So that is the whole idea of doing it. So that technique is called sentinel node biopsy. So when we do that, we reduce the risk of lymphedema to only 2%. So 40%, which was the previous risk, to only 2%. So that difference is a huge difference, and so that makes a lot of difference for the patient in the long run. So for the patients who have undergone sentinel node biopsy, we can almost assure that be assured that we don't have a risk of arm swelling up in their lifetime. Now, there are fewer other things which are there, very important things which have come off late. You were asking about quality of life. So, you want me to talk about those also? Because I was just jotting down, what else is there. You're muted. You're on mute.
Uh, we would like to hear to your points too, sir. Please, sir.
Okay. So, see, other things which are very important for many of the patients is, can we, avoid the side effects of the treatment, and two, can we reduce the duration of treatment? So these two aspects of it have become very, very predominant in the treatment of breast cancer or any cancer for that matter. So what has come in this are the tests which have looked at, can we avoid chemotherapy? So that is one thing. That is the risk reduction tests like Oncotype DX. There are many tests which are there across the world. So they have looked at whether we can avoid chemotherapy for this particular patient. So the same way there are, and they do look at, for good risk patients, we are able to today avoid chemotherapy in very, very selected patients. Now, same way there are things, can we reduce or eliminate radiotherapy for a given patient? So, but when we save breast, traditionally we have always given radiotherapy. So now, can we in a selected group? So, lot of thought has gone into that. And today we also have what is called as intraoperative radiotherapy. That is, we can give radiotherapy at the time of surgery. We don't have to do surgery today and wait for the wound to heal, then give radiotherapy. Today, it is possible to give radiotherapy during surgery itself, and that also reduces the treatment duration. So there are many things which have come up which have looked at the quality of life, because quality of life is an aspect which we have to look at in a holistic perspective. Everything matters. For a patient who's traveling, every day matters. For long duration, there are patients who travel for kilometers and come for treatment. So for them, reduced treatment time means that means saved time for the patient as well as the person who's accompanying. So there are many things of it, many ways we have to look at it.
One question to Poonam madam on the same context. As sir said, whether we can avoid chemotherapy. So how should this point be taken?
So avoid chemotherapy means the risk should be low enough so that if we don't give chemotherapy also the cancer does not recur. So that is the mantra here, means it should be detected at such an early stage that we can avoid chemotherapy, especially if nodes are negative. And we do have all these methods like predictive assays are there, which we can use and see whether the risk is high for recurrence or not. If the recurrence risk is high, we generally don't have an option, and then we have to give chemotherapy to do whatever we can in our hands to reduce the risk of recurrence. But if the recurrence risk is low, yes, in those patients we can skip chemotherapy and we can just stick to hormone therapy. Certainly, it has a very good impact on the quality of life. But more important than the recurrence risk assays is early detection.
Okay. So, question to Dr. Joy again. Sir, what do you advise for follow-up after a surgery? How do you want your patient to follow up to you after a surgery, after breast cancer surgery? Supposedly, the patient has completed his treatment, chemotherapy, radiation, everything. Now the patient is on follow-up. So, how often do you suggest them to come on follow-up? Do we follow the normal guidelines of 3 monthly, 6 monthly, whatever, or do we adjust according to our scenarios?
So as far as possible, I do like to follow the strict guidelines, and I would recommend they do come in 3 monthly or 4 monthly, if not three, and that is a period for 2 years. After 2 years, generally the follow-up moves on to 6 monthly till about 5 years, and then after that we can even follow them up yearly, provided there is no high risk category that they have, maybe BRCA positive or something like that. So these patients who we treat, and after completion of treatment, we do require them to come in 3 monthly. If they have logistic issues, now after COVID, we all are aware of online consultations. So many people do get their tests done in their hometown or wherever they are residing instead of coming down to the main cities. And they do share the reports with us. They do an online consultation, and that is also fair enough. I feel you need not always see the patient. If they do have logistic issues, we can adjust and counsel them online and look at the reports, and they can be home. Maybe once in 6 months they can visit us. So these are the modifications that can be easily made and probably help the patient not spend money and time and effort just to come in for a follow-up. When we were in Tata, we used to have patients coming in from Assam, Dibrugarh, and they would spend 2 days in a train just to reach there. They would see us for 5 minutes and then leave back again. So that's actually something which is, I mean, you wouldn't want that for yourself. Like if you had to undergo the same kind of situation, is something that you would definitely want to avoid. And hopefully, when the cancer centers also are coming up through the NCG and government, they will have a reach to these kind of places, the smaller cities or tier 2 or tier 3 cities. And this follow up or coming to the doctor to check up is maybe hopefully going to get reduced in the future. Muted, madam.
Dr. Sandeep, sir. Sir, what patient, I mean, how do you counsel the patient? These are the signs and symptoms you should look out for. If in cases where recurrence, you should suspect a recurrence and immediately report it to the doctor. On follow-up, how do you suggest?
See, generally, every patient who undergoes breast cancer treatment has to do self examination just like any normal individual. So, self breast examination is a very important part of uh, you know uh, breast cancer follow up. So, in fact, I ask this to every patient who comes back to me and ask them whether they are doing it every month on a fixed date, whichever same pattern as ever whatever we follow for other people. So anything that they feel is suspicious, they think something is abnormal, something new has come and show, because they are not eligible to diagnose it. They have to take medical help in order for diagnosis, because many times it is difficult for us to diagnose in a post-operative situation, especially in breast conservation surgery. We need technology. We need sometimes MRI or ultrasound scan, sometimes PET CT to diagnose what is happening. So anything that they suspect to be abnormal from what was there before has to be reported to the doctor. No need to think what it is, come back. That is the best advice I can give.
Yeah, that is the best advice we can follow. Question to Poonam, madam. What do you think, madam? What can we say about the incidences of breast cancer recurrence after a patient taken complete treatment? What are the chances of them having a recurrence?
So the recurrence rates again depend on the stage of the cancer at initial diagnosis. Stage 1, hormone receptor positive disease have all more than 95% cure rates, whereas if it was a triple negative breast cancer with an aggressive biology, even if it is an early disease, there are relapses in that category. So the recurrence, as Dr. Sandeep explained, that they could be either local recurrences in the breast region or the chest wall region or in the lymph node region, which could be picked up by the patients themselves. But if it is in the viscera, then or in the internal organs, that may require some tests to be done. So
So the
the
key is early diagnosis will cause lesser recurrences. The lesser the tumor, the lesser the recurrences.
yes, yes.
So there is one open question to all of you basically. Finally, we have concluded our question answers. So in general, depending on whatever we discussed, what is the message we would like to convey to the government or health authority? What changes would we like to implement in our current management and protocols and screening protocols, as well as the management? I would like Patil madam to answer first.
So,
Should I repeat?
like this year, the slogan for World Cancer Day was bridging the care gap. So this is to close the cancer care gap, which has been there in the different parts of the world, different parts of society. So gap in the screening program and early detection is lacking. Awareness, and awareness is the main crux of matter. And I think government should go out using all media, whether it's print media, radio, television, social media, everything possible to spread the word. And we have to tell the women that if cancer is detected early, the cure rates are high, survival is high, and the treatment costs also reduces. Sometimes no chemotherapy may be required if it is detected at an early stage. Quality of life will be very good. So we have to make them understand that whatever it is, they should do breast self-examination, even though it is a little controversial in the Western world. But in India, I think breast self-examination is
Is very.
extremely important.
Would Dr. Nayak like to add something to this?
No, I think I was disconnected for a few minutes, but I think Madam has covered almost everything that she had to say. I think that's all. You have
Yes,
any
Joy, sir.
specific question to me, then it's okay.
Anything to add from your end, Joy, sir?
Yeah, so since the question is directed towards partly towards the government schemes or the government institutes, one thing I would definitely like to mention is that currently whatever schemes are available through the government, such as in Maharashtra we have the Mahatma Jyotiba Phule scheme, there is the Ayushman Bharat scheme which is employed in many places. If this kind of healthcare cover is given to the poorer population base and they can actually come in to whichever hospital they want and get the treatment that they deserve, and this is sort of handled in a way by the government, considering their expenses are going to be, I mean, the patients are not going to afford the expenses of treatment. If you today look at a cancer treatment, it's anywhere between 3 to 4 or 5 lakhs in a private institute. So obviously most patients are not going to afford the entire treatment and they have to be held by these schemes. The schemes are mainly in place which cater to the government institutes. So a lot of government institutes have these schemes and they can sort of accommodate the patient into that basis, even because it's a government institute. The costs are covered or subsidized by the government. If they could carry forward this application of the scheme to private institutes as well, it would definitely help cover a much larger population. And the delay times which are encountered in many government institutes, that the patient is there for 1 month or 2 months waiting for a surgery, this also can be brought down in a big way. So applicability of the healthcare scheme which are already there in a wider population base or in a wider institution base, this will definitely help getting across the treatment to the deserving patients at a better way.
From my end, I would just like to add, key since government is giving us treatment costing, a screening costing too should be incorporated in these schemes, because it is only because of loss of screening we are getting diagnosis, which are late and requiring lots of treatment. So if we are detecting it early, at an earlier stage, we are saving also a lot of money, time, as well as life. First should be life. Sorry, I'm putting it last. So we are saving life, we are saving money and time. So I think the costing from the government end should be more towards the screening end also, not only towards the treatment.
Dr. Tejal, I think I beg to differ with you on that. The problem in the society is not of the cost here. It's a question of awareness and education. See, even a lady in the village, if they are able to, detect that there is something happening with her, something which is dangerous, they will approach the doctor. It is not that they will, but the problem is they don't identify it as dangerous. They think it will go. And second level of awareness is, you see, you ask even your doctors who are not oncologists, many general doctors have a feeling that a painless lump is okay, but a painful lump is cancerous. Unfortunately, that sense is also there. So in fact, a lot of my talks, whenever I give an awareness programs and all, I insist that a painless lump is more dangerous than painful lump. Investigate a painless lump. Because we see maybe 10% of early breast cancers may be painful, but 90% are not. So it's a painless lump which is dangerous. So it is that overall awareness that is lacking, and sometimes that blind belief that things will get right. I cannot get it. These are the things which really lead us into dangerous situations. Awareness and education are the only two ways to go about it. No matter how much you include financially all these things, it will end up in problem. And as Dr. Poonam Patil told earlier, self examination in India is key, because we cannot reach the entire population with our screening program. It is an impossible task in India. It will not reach, at least not in our lifetime.
Okay. So it was a nice talk. I would hand it over to Asavari now. Dr. Asavari.
First of all, I would like to thank Dr. Tejal for so skillfully leading this session for us. Thank you so much, ma'am. With that, we wrap up this thought provoking session. Many great points were discussed in this session today on improving the quality of life of affected patients, the urgent importance of early detection and early screening, as well as new insights on intraoperative radiotherapy were also emerged, and the emergent need for a nationwide health policy focusing on breast cancer screening, not just for the population in suburbs, but also for the underprivileged population. I hope all these points get viewed. All these points get the desired views and the attention by the government that is required. And I hope this session was very informative and you were able to become a little more aware about this disease and the importance of getting screened early. Thank you all, and I'd like to thank all the eminent panelists that are present with us today. Thank you so much for taking out time. Our partner for partnering with us, and also I would like to thank our viewers for staying with us till the end. We greatly value your time. Stay happy, stay safe, stay healthy. Thank you so much.
Thank you.
Thank
Thank
you.
you.
Thank you.